So we move into the IC course on CSCR, and I request Dr. Lekha to please give the first talk on current understanding of the pathogenesis of central serous chorioretinopathy. Dr. Lekha is a senior consultant in medical retina in our institute in Cochin, and she has got years of experience.
Thank you, sir. And I thank the scientific committee of AIOC for giving me this opportunity. Central serous chorioretinopathy, or CSCR as we call it, is a potentially blinding disease of the pachychoroid spectrum characterized by serous retinal detachment with or without pigment epithelial detachment and a thick choroid. The risk factors associated with CSCR ranges widely from corticosteroids, increased sympathetic drive, systemic hypertension and autonomic dysfunction, psychological stress, infection, inflammation, ocular causes like hypermetropia and a thick choroid, and genetic factors, of which the most recognized risk factor is the role of steroids, which can be explained by the mineralocorticoid pathway hypothesis. Normally, the glucocorticoid or the cortisone is converted into cortisol by the enzyme 11-beta hydroxysteroid dehydrogenase type 2. This enzyme is relatively deficient in retina and choroid, so this conversion is not happening, which means there is excess of glucocorticoid in relation to aldosterone, and they goes and illicitly occupies the mineralocorticoid receptors. Normally, glucocorticoids causes vasoconstriction, but here when they occupy the mineralocorticoid receptors, they could give the opposite effect. They cause vasodilatation, it becomes pro-edematous and pro-inflammatory, and all this is happening through the upregulation of endothelial calcium-dependent potassium channels. It also causes loss of RP adhesion and Brooks membrane remodeling, finally leading to SRF accumulation. So this means that because this MR activation is pathogenic, there could be a role for long-term MR antagonist in the management of this condition, and this has been validated in rodent models. Genetic associations are also important because several familial cases have been reported, but no clear inheritance pattern has been established. The various genes that has been associated includes complement factor H, which binds to adrenomedulin and stimulates choroidal dilatation, and another is cadherin 5, which is important in maintaining the integrity of endothelial cell adhesions, and dysfunction of this can lead to leaky intercellular junctions. But it's more likely that these genetic variations combined with a triggering event such as steroids can explain the CSR in a subset of patients. Now, if we go into the pathogenesis, we can see that the understanding of the disease as well as the terminology used to describe it has evolved over years. It started off as retinitis by von Graffe, then the role of stress was recognized from that time itself, and it was Momini who demonstrated that the leak is actually happening at the level of the retinal pigment epithelium, and Donald Gaz was the first person who proposed the role of the choroid. He suggested that as the choroidal hyperpermeability that is important in the pathogenesis, and finally with the introduction of the pachychoroid spectrum, CSCR became an important entity of this condition. So what is this pachychoroid driven process? Which means we have a thick choroid with abnormally dilated vessels known in the Haller's layer known as a pachyvessels, and this dilated layer will lead on to compression of the inner layers with attenuation, ischemia and vascular remodeling, and this progress to RP dysfunction with breakdown of the blood retinal barrier where the fluid escapes into the subretinal space. And steroids also have a role in this pathway, and this is all basically showing the inflow mechanism where the fluid is coming from a thick and hyperpermeable choroid. But what actually causes this pachychoroid and this pachyvessels? It's found that the dilatation of these vessels occurs due to back pressure because of some abnormality in the outflow mechanism, and there is what is called as a venous congestion in the choroid due to various factors like asymmetrical veins, intervortex vein anastomosis, and arteriovenous anastomosis, and this is exacerbated by a thick sclera which is often found in these eyes. And this sort of continues as a cascade with continuous chronic venous congestion leading to choriocapillaris changes, again leading to anastomosis formation, and this is now what is known as a venous overload choroidopathy, which I am going to explain in my next few slides. So this is a normal picture of a ultra wide field SEG angiography and the Swepsos OCT image, and it is because of the availability of these newer modalities that we have been able to understand the venous drainage in the choroid and the vortex veins. Now, compared to the normal picture, we can see here that the inferior vortex veins are much more dilated compared to the supranasal vein. So there is an asymmetry, which you can see in this web source image also, and it is found that while asymmetry can be seen in normal subjects, it is seen in almost 100% of eyes with CSCR. And in such situation, in asymmetric veins, when the dominant vein is congested, then it can lead to increased permeability of choriocapillaris in the macular region. Apart from these asymmetrical veins, there can also be intervortex vein anastomosis. Normally, the vortex veins do not cross a watershed zone. Here we can see these veins cross and they form anastomosis. And in the Swepso's OCT image, we can see this anastomosis is much more common in CSCR compared to a fellow eye and a normal eye. So these kind of anastomosis can increase the venous congestion. It can also be a consequence of the venous congestion, and maybe resolution of these anastomosis could be taken as an endpoint biomarker to monitor the therapeutic response. And if you see the spectrum, we can see as the anastomosis increases, the choroidal congestion is alleviated, leading to a decrease in the thickness of the choroid. Now, choroidal circulation is generally, the arterial system is considered as an end arterial system, but it is possible that small anastomotic connections can form between the arterial branches of the short posterior ciliary artery. It is also possible that arteriovenous anastomosis, which could be physiological, can form, and they are found to perform essentially the same function of physiological AVAs elsewhere in the body, like lung, episclera, etc., just maintaining the blood flow, thermoregulation, etc. And dysregulation of these physiological AVAs can contribute to the pathophysiology of pachychoroid. Now, it is speculated that apart from this, there could be a pathological variant, which is the acquired type, or better known as arteriovenous fistulas, can also form of sites of AV crossings. And AVFs also have been manifested to occur elsewhere in the body, and one common example is the dural AVFs. And these authors have found a lot of striking similarities between the AVFs in CSCR and dural AVFs, right from their clinical imaging features. And they say if it is a single AV, it causes an acute presentation, where if it is a multiple or persistent AVFs, it causes a chronic presentation. But our challenge is to demonstrate this because of the limitation of the current multimodal imaging that is available. And finally, this is exacerbated by a thick sclera because that restricts the amount of fluid permeating through it. And also there is a longer intrascleral course of the vortex veins, which adds to the restriction of the outflow. And again, we have not been able to measure the posterior scleral thickness, but anterior scleral thickness have been found to be higher in CSCR eyes, and this can be taken as a surrogate marker. And this raises a question of the role of full or partial thickness scleral window with or without ICGA guided vortex vein decompression as a treatment modality. So to summarize, this is the venous overload choroidopathy pathways as proposed by Spade et al. And we can see that there is either due to intrinsic or extrinsic effects, there is venous overloading, which leads on to remodeling and intervortex vein anastomosis. And if this initially starts as a compensatory mechanism, but in the long run, it is detrimental because it adds on to the choroidal venous congestion. And all this can occur without any clinical manifestations as seen in the yellow background. But if it continues for a long time, it eventually leads on to leakage through the RPE with subretinal fluid accumulation. And there it becomes clinically manifest, as you can see in the red background. And finally, if the fluid is able to exit through the sclera, then it is decompensated. It's compensated and the choroidal is decompressed. And this is shown in the green background. So to summarize, understanding of the pathogenesis still remains incomplete. Advances in multimodal imaging have definitely improved our understanding, and the latest theory focuses on venous overload of choroidal circulation. And this also highlights the role of the newer modalities like ultra-wide field ICGA in the evaluation of these eyes whenever it is available. Systemic conditions, mineralocorticoids, and genetics also have a role. But beyond all this, there could be some primitive abnormality which is mandatory to complete the CSCR phenotype, because as we know, typical CSR can still exist without pachychoroid. So better understanding of these mechanisms should lead to design and evaluation of novel therapies which can improve the visual outcome. Thank you.
Thank you, Lekha, for that very exhaustive and very concise presentation. I think the topic is open for comments and discussion for a couple of 2 to 3 minutes. Any questions from the audience?
Yes, sir. Sorry? Yeah, even like it sort of acts mainly as the mineralocorticoid pathway hypothesis itself. So there are reports showing that, but I really don't. I think higher levels, sir.
There is no male predilection. There is no male predilection for CSR. No, I'm just saying testosterone. Do we have evidence for testosterone?
There are reports which says all these hormones may be elevated in these patients.
So just to add to that, testosterone backbone is the same as the steroid backbone.
Yeah.
So it is known to be associated, and people who take these hormones for lack of testosterone, some of them do present with CSCR. So there may be some correlation there.
Yeah.
Yes, sir. See, not one mechanism can really
No, I
explain
think
CSCR.
basically we still do not know. See, there are two aspects as far as CSCR is concerned. One are the structural abnormalities which have been described, like venous overload choroidopathy. There are different phenotypes of central serous chorioretinopathy. As we go through the course, that's the main emphasis on which I'll be talking about. And probably these are situations where there are different grades of venous overload choroidopathy that we are seeing in each type of patient. So we really do not know what are the other aspects. I mean, if you see the literature on CSCR, there are so many factors which they have said are risk factors for central serous chorioretinopathy, but still we really do not have very concrete evidence to say that, one particular thing is really responsible for the disease. I mean,
Okay. That I think I can explain with the latest theory where they say it is due to some AV anastomosis, and if it is a single anastomosis, it occludes on its own, and the CSR resolves. If there are multiple anastomosis or if they are persistent anastomosis, it can lead to chronicity. There are several theories, like with just one mechanism, you cannot explain everything. And again, related to the first question, it's not that in everybody CSCR is predisposed by steroids. There are many individuals, uveitis patients, we give steroids for longer term, high dose of steroids, they never develop. And and for steroids, it's just the usage, it's just not even the dose or the duration that matters. So still we have not fully understood what, and it's a multifactorial thing. Lifestyle modifications more than dietary. Lifestyle modifications are important, CSCR. Type A personality, control of stress, adequate sleep, all these are important. But dietary per se, I'm not sure. Maybe again related to steroid use for some allergy.
So I had a patient recently who had CNBM in one eye treated with Paginex, and he went out and took some medicines from Baba Ramdev and developed CSR in the other eye. And has been having anti-VEGFs for last 13 years, earlier based in US, now come to India. I treated him with micropulse in this eye. He has subsided. He has stopped the inciting agent, that is the Baba Ramdev medicine, I don't know. So those could be involved.
Can I have one question? One. So I just wanted to know what is the current thinking on the influence of topical steroids on the development of CSCR. And we are always talking about systemic and steroids in every other form, but not really of topical steroids and its association with CSCR. So I would like to know your comments on that.
Topical steroids are the least likely to cause. Yes.
So is there any particular reason?
I am not too sure.
There is actually I had a patient who had previous CSCR who underwent cataract surgery, and 1 month on steroids, within 3-4 weeks patient developed the fibrin CSCR, and it took a long time for resolving. I had a patient like that, but topical as such is unlikely to.
It is not mentioned as an association.
Yeah.
So
it's just a comment on the diet and what you said about the medication taken. I also have a fair number of patients who are on some kind of supplements or something that is not very well known over the counter kind of medications, and they started, it could be topical, it could be hair product, cosmetic, supplements, and true enough they actually develop CSCR, and when you tell them to stop it, So the
No, we do
question
not
here
know.
is that
Ranjana,
it
I
may
don't
go away,
think that we can say that, see, this is like any disease is like that. We always equate it to something. And
correct.
unfortunately, these are diseases which have got what do you call remission, exacerbation.
Yes.
So we really
So
do not know what
becomes
exactly
difficult.
caused
That's
the
right. It
remission.
becomes
So,
difficult to tell whether the drug has caused it or the natural
yeah.
remission of the disease, unless we do a
But
control
as far as
trial or
steroids
something.
are concerned, I think there is
Definitely.
enough evidence to show
Yeah.
that steroids
In
in any
Singapore, we
form
have
can.
ginseng, which also has kind of steroid properties. So that one is a definite known factor.